Gartner cyst. This is a benign fluid-filled cyst that arises from the remnants of the Gartner cyst, a vestigial structure derived from the mesonephric disc in the femur, typically found on the anterior lateral wall of the vagina, most commonly in the upper third, though it can extend along the length of the vagina. Embryology and the pathogenesis. During the embryogenesis, the Wolffian ducts regress in the female, leaving behind the remnants known as the Gartner duct. Incomplete regression of the persistence of the duct can lead to the cyst formation. Congenital origin from the mesonephric duct remnants can occur spontaneously and it is not linked to the infection, trauma, or the malignancy. Asymptomatic, most cases are discovered incidentally during the routine gynecological examination. Symptomatic like vaginal discomfort, pain or the pressure, especially during the intercourse, dyspareunia, palpable, soft and cystic marks on the vaginal examination. Large cyst may compress the adjacent structure, causing the urinary symptoms like frequency, urgency, or the retention. Unlike Bartholin cyst, Gartner cyst is typically non-tender and located more superiorly in the vaginal wall. Differential diagnosis: Bartholin cyst, posterior lateral location often tender. Means duct cyst, periurethral location. Inclusion cyst, both surgical or the traumatic. Endometriotic cyst associated with the cyclic pain. Clinical examination led to soft compressible mass on the anterior lateral vaginal wall. Imaging studies like ultrasound identify the cystic nature and the exact location. MRI preferred for the detailed anatomical delineation, especially for the larger cyst or the uncertain diagnosis. Histology lined by the tibial or the columnar epithelium, consistent with the mesonephric origin, not atrophy or the malignant potential. Complications like large cyst may cause a urinary obstruction or the recurrent infection. Rare cases of the cyst rupture leading to the localized inflammation. Treatment is a symptomatic cyst, no intervention required, regular follow-up if large. Symptomatic of the large cyst, surgical excision, definitely treatment with the minimal recurrence risk, drainage temporary relief, but higher recurrence rate compared to the excision. Gartner cyst originates from the remnants of the mesonephric Wolffian duct, commonly located on the anterior lateral wall of the upper third of the vagina. Most cases are asymptomatic and discovered incidentally during the gynecological exams. Symptomatic cysts present with the dyspareunia, vaginal discomfort, or the urinary symptoms. Differentiated from the Bartholin cyst by its superior location and the non-tender nature. Ultrasound and the MRI are the key diagnostic tool for the confirmation and anatomical localization. Histology shows the cuboid columnar epithelium without a malignancy. No malignant potential, making it a benign lesion. Surgical excision is the treatment of your choice for the symptomatic cyst. Post-surgical recurrence is started with a complete excision. Large cyst may cause the urinary retention or the frequency due to the compression of the bladder. MRA provides a better visualization for the large or the complex cyst. Derived embryologically from the Wolffian duct remnants, unlike the Mullerian cyst, which arises from the paramesonephric duct. Important to differentiate from other vaginal cysts in the clinical practice. No known association with the infection, trauma, or the malignancy. Drainage offers the temporary relief, but higher recurrence compared to the surgical excision.